Hello, my name is Anna Ingram. I am a third-year occupational therapy doctoral student at Gannon University. Today's competency will be going over sensory testing lateralization. Before we get started, I have several goals I would like you to keep in mind as we progress through this presentation. First of all, I would like for you to be able to define right-left discrimination. Then, list diagnoses associated with right-left discrimination impairment. Describe common assessments of right-left discrimination. Explain indications of right-left discrimination impairment. And finally, demonstrate how to perform Ayer's right-left discrimination test. There are a couple of definitions I would like you to keep in mind throughout the remainder of this presentation. The first is lateralization, which is the localization of function on one side of the body versus the other side of the body as a result of the development of specialized functioning in each hemisphere of the brain corresponding to the side of the body that each controls. This can also be thought of as right-left discrimination, which is when a person can use mental motor imagery to determine which side of their body a limb is on. Some important functions of lateralization to keep in mind are having a sense of body awareness, being able to motor plan, using language, both verbal and nonverbal, the ability to write, and to have a sense of navigation. Right-left discrimination is not generally well developed until a person is about 7 years old. When this function is developed, it contributes to body scheme, which is the input of a lot of sensations that help us create an idea of where our bodies are in space, how our bodies move, and what is external to our bodies, which can trigger and guide movement. It also helps us explore environments in a safe, constructive way. Left-right discrimination involves 4 main things, including sensory integration, expressive versus receptive language, an understanding of the right-left concept, and visual spatial elements. In the next several slides, I will break down each of these 4 things more in depth. Beginning with sensory integration, this is a neurological process that organizes sensations coming into our bodies. It makes it possible for us to effectively participate in our daily activities and tasks. Typically, you would think of the 5 sensations, but there are in fact 7, and they are vision, auditory or hearing, tactile or touch, gustatory or taste, olfactory or scent, vestibular, our sense of balance, and finally proprioception, which is our sense of our bodies in space. Emphasizing proprioception is important because lateralization or right-left discrimination falls under the umbrella of proprioception. Our ability to identify where our bodies are in space and know how we're moving and what's moving around us gives us that sense of right-left discrimination and the ability to do a lot of our daily activities in a safe and meaningful way. Another important function of lateralization is expressive versus receptive language. You probably use this on the day-to-day basis, both when speaking to others or receiving language from others. It's important for us to be able to identify whether we're moving one way versus another and understand when someone is telling us something related to a directional cue. This can be important for a variety of reasons, but most importantly, our safety. This slide will be brief, but in order to properly identify right versus left discrimination, we need to understand the concept of right versus left. This is something we're typically taught from a young age in elementary school or before, and it's something we need to continuously understand and have the cognitive capacity to understand through our day-to-day life and navigation. Finally, there is the visual spatial element. It is important for our concept of right-left discrimination to stem from our ability to internally picture our bodies in space. This is done through mental rotation, and this is the ability to rotate 2 or 3-dimensional objects in our minds. There are 2 types of mental rotation: object-based and egocentric mental transformations. In an object-based transformation, the observer's position remains fixed, and the object is moved mentally in relation to the surrounding environment. So in this case, I might be standing and I see a kite sailing by me, and I know that the kite is moving externally to my body, and I can see it floating from one side to the other, and I know that it's moving from right to left in this instance. The second one is egocentric mental rotation transformations, and this is one's own perspective changed mentally to imagine rotating one's own body in relation to the stimuli. It's important for us to touch on the anatomy and neurology that makes it possible for us to have right-left discrimination, and the major part of the brain that is responsible for this is the parietal lobe. The parietal lobe is split into left and right. When there's damage to the left parietal lobe, it can result in right-left confusion, difficulty with writing, difficulty with mathematics, disorders of language, and the inability to perceive objects normally externally to us. Damage to the right parietal lobe can result in neglecting part of our body or space, which is also called contralateral neglect. This is often seen with stroke. Right side damage can also cause difficulty in making things, which is constructional apraxia. It can lead to having a denial of the deficits a person is experiencing, and it can impact one's drawing ability. If you look at this list again, you'll realize that all of the things that can result due to damage of the parietal lobe are listed on my slide earlier in the presentation, quickly going over functions of lateralization. For this next part of the presentation, I'm going to go over some of the common diagnoses that can result in a deficit in lateralization or right-left discrimination. The first diagnosis I'm going to discuss is a cerebrovascular accident, CVA, or more commonly known as a stroke. A CVA results from an interruption of blood flow to the brain that can be the result of either a blockage or a bleed. When there's a blockage or a bleed, it can result in a poor supply of oxygen to the brain and cause brain damage of varying amounts depending on the location and severity of the stroke. There are 2 different types of strokes, two main types of strokes, ischemic and hemorrhage. An ischemic stroke is when there's a blockage of a blood vessel in the brain causing a clot, and a hemorrhagic stroke is when there's a bleed in the brain, spreading to some of the other vessels, causing damage. A CVA can occur anywhere in the brain, and there are other classifications apart from ischemic and hemorrhagic, but typically falls within those 2 categories, and it is typically characterized as either being a left stroke or a right stroke. We're going to take a quick look at the major common deficits of right versus left stroke and the deficits that directly impact our sense of lateralization. With a right-sided stroke, you can have weakness or paralysis on the left side of the body, an impairment of sensation including proprioception, which, as I discussed, is an important umbrella that falls above lateralization, spatial and perceptual deficits, unilateral inattention or neglect, which will cause a person to completely disregard one side of their body, visual deficit in left half of visual sphere in both eyes, which again can impair kind of that inattention to one side of the body, and impulsive behavior, quick movements, and errors in judgment, which can impact the way we navigate our environment and jeopardize our safety. With a left-sided stroke, we have loss of voluntary movement and coordination on the right side of the body, which might make it difficult to comprehend what's happening on that side of our body. Again, we see that impairment of sensation, including proprioception, which is that important sense of where our body is in space. We can see language deficit and global aphasia, which is a function of lateralization. We can have blind spots to the right of our visual field, making it difficult to regard that visual field. And here, instead of being impulsive like on the right side, people that have a left-sided stroke might be more slow and cautious and have memory deficits and cognitive challenges. The next diagnosis I'm going to discuss is traumatic brain injury. There are two types of TBI, which fall into closed and open. When someone has a closed TBI, it means the injury does not penetrate the skull. This is often seen in vehicular accidents, which cause contra coup injuries, which is where upon impact, the brain will hit one side of the skull and then bounce back and hit the other. And this could happen several times depending on the severity of the impact. Open TBIs is when there is a penetrating injury to the head, like with a gunshot wound. They are classified into mild, which is when there's a loss of consciousness for less than 30 minutes, moderate, which is a loss of consciousness for 30 minutes to 24 hours, and severe, which is a loss of consciousness for more than 24 hours. TBI deficits can be seen across every system of the body, but the three I'm going to focus on as being related to lateralization are cognitive, motor, and sensory perceptual. With cognitive, this can be a result of a loss of consciousness and cause confusion, a shortened attention span, problem-solving difficulties, memory deficits, poor abstraction, or the poor ability to mentally comprehend objects or picture objects. I think of that mental rotation that's important for our concept of right-left discrimination. It can also decrease our awareness of the self and others, so our body scheme is no longer complete. Motor deficits occur from paralysis or weakness, which if we're having paralysis on one or both sides of the body, we're going to have a really difficult time differentiating our right versus our left side. It can cause spasticity, which is that high muscle tone, poor balance, poor endurance, poor planning of motor movements, which is again thinking back to proprioception and the ability to think about our bodies moving in space. It can also cause tremors and poor coordination. Finally, there are sensory and perceptual deficits, which can include a loss of sensation or heightened sensation in body parts, left or right-sided neglect, which is, of course, the major topic of this presentation, a poor understanding of limbs in relation to the body, going back to that body schema, and proprioception again, and visual deficits. Another diagnosis is complex regional pain syndrome, or CRPS. This is a difficult diagnosis for people to get sometimes because presently this diagnosis is not fully understood by medical professionals and there is no gold standard assessment for its diagnosis. Currently, there are considered to be two types of CRPS. Type 1 is a non-nerve related injury associated with trauma, so this could be a fracture or surgical intervention. These account for about 40% of CRPS cases, but even within those 40%, this is a very rare injury with only 3.8 to 8.3% of surgical cases resulting in this type of injury. The second type of CRPS is due to nerve lesion, and this is a major peripheral nerve injury, say maybe a brachial plexus injury. The main symptom of CRPS is pain that is considered to be disproportionate or unexpected related to a typical injury progression. For example, if someone had a surgery to repair a fracture in their wrist, after several weeks, it's typically expected that pain will really start to diminish, that fracture's healing. There may still be some stiffness and swelling, but someone with CRPS will still have extremely excruciating pain with that injury. CRPS can also feature changes in the perception of temperature, neglect of the limb or the area where the CRPS is occurring, allodynia, which refers to pain from a stimuli that would not generally be painful. For example, maybe some clothing you're wearing brushing against where you're experiencing CRPS might be painful when typically it would not. And one can also experience other neurological abnormalities associated with central sensitization. The pain from this diagnosis can be extremely debilitating and can prevent people from participating in their daily occupations. I actually had a client in my fieldwork last semester who had CRPS, and she was extremely frustrated because she was an avid yoga practitioner. She had an open reduction internal fixation in her left wrist, and it had been, I think, over 12 weeks. And she was still having excruciating pain and difficulty moving her joints. And she was so disappointed that she couldn't partake in her usual yoga sequences. And she also had issues completing other things around the house, like cooking and cleaning. So it was a really difficult diagnosis for her. When someone is experiencing chronic pain, either from CRPS or another injury or disability, this can impact the cortical processing in our brains, which impacts both sensory motor integration and body scheme, resulting in impaired right-left discrimination. Those who experience chronic pain have been found in several studies to have a slower response time and poor accuracy when identifying images that correspond with their affected limb. I found 3 assessments that address right-left discrimination. The first is Ayer's right-left discrimination test. The second is point to body parts on command test. And the third is the Bergen test of right-left discrimination, which I found across several articles testing lateralization. The Ayer's right-left discrimination test is a subtest of the Southern California sensory integration test. This test is often performed with children and consists of 10 instructions. To administer this test, you as the tester are going to sit directly across from the child or your adult client. The first instruction, you're going to ask them to show you their right hand. Number 2, you're going to ask them to touch their left ear. Number 3, you're going to say, take this pencil with your right hand, and meanwhile you will hold the pencil with both hands resting on your knees. The fourth instruction is to ask, now put it in my right hand, and you're going to hold both hands palm up on your knees so they can place it in the proper hand. The fifth instruction is to ask, is this pencil on your right or left side? The pencil will be in your left hand and your foot will be in front of your client's right shoulder. The sixth instruction, you're going to ask them to touch their right eye. The seventh instruction, you will ask them to show me your left foot. The eighth instruction, you will ask, is this pencil on your right or left side? And you will hold the pencil in your right hand in front of the client's left shoulder. The ninth instruction, say, take this pencil with your left hand, and you're going to hold the pencil with both hands resting on your knees. And the last instruction, you're going to ask them to put the pencil in your left hand while holding both hands palm up on your knees. Now, to score Ayer's right-left discrimination test, you're going to score each of the 10 items. A client will receive 2 points if they correctly complete an item within 3 seconds. A client will receive 1 point if they correctly complete an item within 4 to 10 seconds, but no more than 10 seconds. A client may correct him or herself within that allotted 10 seconds, but will receive no points if they remain incorrect. A client may have a command repeated 1 time, but no more than 1 point may be allotted for a correct response, even if that response is within 3 seconds. Now, this is a subtest of a larger assessment, so in terms of score interpretation, there's not a lot of information, and that will also be a trend with the next 2 assessments I have here. There is currently no gold standard for sensory testing of lateralization. So we have some tests to get a basic look at our client's sense of right-left discrimination, and we can use our clinical judgment from there. This test does have some psychometric properties. It has been standardized for children aged 4 to 9. As of now, it is still not standardized for adults. However, inter-rater reliability was established for a sample of adult head trauma clients, so someone that may have a TBI, the diagnosis that I mentioned earlier. The validity for this test is adequate as long as aphasia, apraxia, and other primary motor problems are ruled out. The next test of right-left discrimination I will go over is point to body parts on command test. The client may point to a body part in question on either themselves, the examiner, a doll, or a printed figure of a human. The examiner will sit directly across from the client in order to administer this test. Like the Ayers test of right-left discrimination, this test also has a list of 10 instructions which you will read aloud to your client who is sitting right across from you. You can pause the video to take a moment to read over this list. These questions are going to give you a sense of their ability to to discriminate right from left, and they're also going to give you an idea of their own body scheme. In terms of psychometric properties, this is a non-standardized assessment. A client is considered to have intact right-left discrimination if they can correctly demonstrate knowledge of all requested body parts in an appropriate length of time. Unfortunately, we are given no parameters as to what this appropriate length of time is, so a clinician must use their judgment. Validity for this test is considered adequate if other diagnoses, including aphasia, apraxia, and primary motor problems, are ruled out. The inter-rater reliability has been established on a variation of this test for adults who have suffered head trauma, again, going back to maybe a TBI client. The third test of right-left discrimination I want to review is the Bergen right-left discrimination test. This is a paper and pencil test that consists of sequences of stick men, of which either the front or the back side is shown. I have an example that I drew in a couple of slides, so you'll get to see what that looks like. Now, this test includes 3 subtests. The first subtest, the back side is shown of all stick men. In the second subtest, the front side is shown for all stick men. And in the third test, either the front or the back of the stick man is randomly presented. So the person taking it will have to look at the stick man and determine whether it's the front or the back to get an idea of right versus left. The subtests have 2 different variations. One can be given a concrete or an abstract version of the subtest. In a concrete version, the stick men will have faces on the front side, and you'll see hair on the back side to distinguish front from back. On the abstract version, the face will be white if it's the front of the stick man, or black if it's the back of the stick man, to show, again, front versus back. And because that's the abstract version, one has to remember the white versus black correlates to front versus back, and that can make it a little more difficult. Each of the subtests comprises of 3 paper sheets, each showing 16 stick men, resulting in 48 items per subtest. Within each of these 3 subtests, stick men are drawn with different arm positions, including either both arms crossing the body's vertical midline, only one arm crossing the vertical midline, or no arm crossing the vertical midline. To complete the assessment, for all subtests, participants are asked to mark either the left or the right hand of each stickman with a pencil. For the instruction of the subjects, the letter R or L is printed beneath each stickman item, indicating whether they need to fill in the right hand or the left hand. Subjects are given 90 seconds to accomplish the items of each subtest, and 1 point is to be awarded for each correctly marked hand. Here is the example I drew of an abstract alternating view of a subtest. Notice it's the abstract version because the stickmen either have a black or a white circle indicating back versus front. Look at the position of the arms and remember each of the 3 ways that the arms can be positioned relative to midline. And also notice that the hands are white circles so the client can fill in with a pencil whether it's the right side or the left side. Before I conclude this presentation, I want to go into one intervention that has been found to be successful with populations who have difficulty with right-left discrimination. Graded motor imagery is a treatment that seeks to restore altered body imagery and awareness. Graded motor imagery aims to activate the cortical networks in the brain involved in sensory motor processing in 3 progressive phases. The first is a left-right discrimination task, which brings in recognition. So a person might look at some images of a limb and they have to figure out if it's the right or the left side. The second is imagined movements of the affected limb. This goes back to that mental rotation I was talking about earlier in the presentation. So being able to internally visualize something in a 2D or 3D form. And the third is mirror therapy, which acts on visualization of your affected limb moving without the experience of pain. This process really gradually encourages movement without bringing about that sharp pain that often results in fear of movement. So it can really help a person get over that fear over time and actually begin creating movement patterns again. Thank you for listening to my presentation on sensory testing lateralization. On the next few slides, you'll find my list of references.